My name is Jason Sheehan, and I am a professor of neurosurgery at the University of Virginia. I am here to moderate a session on focus ultrasound and brain tumors. It's a virtual panel discussion and series of presentations as part of the 7th International Symposium on Focus Ultrasound. Our speakers today will include Dr. Francesco Prata, who is from Milan, Italy, Dr. Adam Sonov, who's from Northwestern University, Dr. Liu, who's from National Taiwan University, Dr. Michael Lim, who's chair of neurosurgery at Stanford, and Dr. Chun, who is at Washington University in St. Louis. So I hope you'll enjoy this series of presentations, and then we'll have a discussion to follow. Thank you.
Hello, my name is Adam Sonov, and today I'll be sharing with you some of the work we're doing with the use of ultrasound-based blood-brain barrier opening and how we're applying it to deliver paclitaxel to the brain for glioblastoma patients. We'll share our experience between bench to bedside. So the first is disclosures, as you see right here. Also acknowledge a kind support by NCIR1 to fund this study, as well as Carthera and Celgene collaboration. This work I'm presenting today was done in collaboration with Roger Stuck, who's my oncology partner in this project. So first, I'd like to just state that blood-brain barrier disruption by an implantable ultrasound has been demonstrated already in patients. This is an interesting approach because by placing the ultrasound on a window in the bone, you can avoid the attenuation that the bone has on the sound waves. So you can accomplish deep and wide blood-brain barrier opening with this approach, as you can see on these pictures from a paper recently published by my colleagues in France. There's actually a further elaboration of this concept in a second-generation device that now has 9 ultrasound emitters all in a mesh. And so you can accomplish a wide region of the brain that suffers blood-brain barrier opening. And this has been demonstrated to be safe in a multi-center clinical trial that we were the first participants in the US. I'll share some of these first patient experiences. The first patient that we did this in the United States. You see here the implantable skull ultrasound. There's a port right here where the percutaneous needle is inserted in order to activate it. Here's what the X-ray looks like after surgery. It's really interesting because the images you get will show you that the sound waves can get very deep, as you can see on these post-sonication pictures. You can go across the tentorium or the dura into the brainstem or the patient's cerebellum. It's a very powerful approach. Here's another case. This is a patient I did a resection of a recurrent glioblastoma and implanted the device. Post-op, you see no enhancement. Pre-sonication, you see minimal cavity enhancement, but post-sonication, you see a wide region of enhancement showing that blood-brain barrier has been opened in these regions. We'll focus today on paclitaxel, given that it's one of the most potent drugs against gliomas. In vitro, using human cell lines, you have data here showing you that paclitaxel is as potent for gliomas, including low-grade gliomas and glioblastomas, as it is for breast, lung, and pancreatic cancers. These are the tumors for which this drug is already approved. Moreover, paclitaxel, as you can see on this graph on the right, is about 1,400-fold more potent for glioblastomas than it is temozolomide. So the clinical experience with paclitaxel so far has not been very encouraging. There's several studies that show that when systemically delivered, it's not really leading to any efficacy. There was one study in which it was delivered through convection-enhanced delivery, and they had a 73% response rate. This is an old study that used Primavor-based formulation of paclitaxel, and there were a lot of complications related to the local delivery of this drug using CED. An interesting pharmacokinetic study was done back in the 90s that revealed that paclitaxel can be detected in the tumor tissue, but it's actually not detected in the peritumoral brain, which is the site where most recurrences occur in glioblastoma. Paclitaxel comes in 2 FDA-approved formulations. One is Taxol that has Primavor as a vehicle, and the other one is an albumin-bound paclitaxel. It's worth mentioning that Taxol, or the CREM4 formulation, it leads to more peripheral neuropathy. So these are, of course, concerns when delivering this into the brain. So we compared these two formulations and first determined that actually albumin-bound paclitaxel exhibits a better brain penetration, as you can see on this graph, than the CREM4 formulation. This translates into better efficacy in mice bearing human patient-derived glioma xenografts, as you can see in two separate models on the left as well as on the right. The dose that you can give for albumin-bound paclitaxel or Abraxane is much higher than what you can achieve with the CREM4 formulation, as it's not as toxic. So with an ultrasound-based blood-brain barrier opening device, we were able to further increase the concentrations in the brain of albumin-bound paclitaxel in non-tumor bearing mice that do have blood-brain barrier intact. And you can see here we use fluorescein to map and visualize the area that has blood-brain barrier disruption. And you see there, we achieve therapeutic concentrations that are higher than the ones necessary to kill most human glioma cell lines. This translated into some modest but significant efficacy in overall survival. I'm not surprised that the increment of using the ultrasound is only modest, given the fact that patient-derived xenografts do actually have no blood-brain barrier considerations. In other words, these tumors are not infiltrative, and therefore they're not really hidden by the blood-brain barrier as human disease is. We also compared the toxicity of both formulations, and it turns out that when given it on a single dose, there's already more toxicity when ultrasound is combined with CREM4-based paclitaxel than with Abraxane or albumin-bound paclitaxel. In fact, CREM4 alone is also significantly toxic when doing repeated doses, as you can see on the survival curve, whereas albumin-bound paclitaxel is not. So this led us to apply for an IND that was, we're grateful, just was awarded by the FDA, and then R01 that is funding this study we just opened. It's a phase 1/2 clinical trial in which we will determine as a primary endpoint the maximal tolerated dose and dose limiting toxicity of different dose levels of albumin-bound paclitaxel delivered into patients with glioblastomas using skull implantable ultrasound. There's a phase 2 portion of this study in which we'll do additional patients at the highest dose level to do an exploratory preliminary efficacy assessment looking at overall survival at 1 year from start of treatment. Our hypothesis that we'll achieve equal or greater than 65% overall survival at 1 year versus a historical benchmark of 45% 1 year for resectable patients. This is the support and acknowledgements. This is a multi-collaborative work done by a lot of people, in particular Dan Zhang in my lab, who did a lot of the preclinical work, and as I mentioned before, Roger Stoop, also kind support by Carthera. Thank you.
Good morning, everybody. This is Dr. Prada. I'm a neurosurgeon based in Milan at the Carlo Besta Institute, and I'm a senior fellow at the Focus Ultrasound Foundation. And in this presentation, I will discuss briefly sonodynamic therapy for brain tumors. So when we're talking about sonodynamic therapy, among all the possibilities offered by therapeutic ultrasound, we are in the field of low intensity, low frequency ultrasound. And the concept of sonodynamic therapy is similar to that of photodynamic therapy, and basically there is a source, there is an energy, source of energy that interacts with the agents called, that can be sensitized by this form of energy. The tissue, the target tissue is exposed to the sensitizing agent, and one of the requests for these agents is to selectively accumulate within the tumor. Subsequently, the agent is exposed to the target area, is exposed to the ultrasound. Ultrasound and the sensitizer per se do not really affect the target area, but what really generates the damage to the tumor is the interaction between the two. However, it has to be said that this can be discussed because ultrasound can have a sort of effects, at least on brain tumors. There are different mechanisms of action and different bioeffects that are elicited by the interaction between sensitizers and ultrasound. The main effect that determines this mechanism of action is a sort of a microcavitation, which in turn generates reactive oxygen species. And of course, as I said, there are mesomechanical mechanisms, and less probably there is generation of hyperthermia. All these mechanisms of action are able to induce apoptosis and necrosis within tumoral cells, and then induce anti-angiogenetic mechanisms and immunological effects. One of the good news for brain tumors is that 5LA is a perfect sonosensitizer because it determines the accumulation of protoporphyrin 9, which is actually the substance with which ultrasound interacts. And as we know from the use of 5LAs for intraoperative guidance, it selectively accumulates within the tumor in gliomas. And in fact, there are a series of preclinical studies that showed that 5LA is a great sensitizer, and the combination of ultrasound, as it has been showed by Dr. Sheehan's group at UVA, so the exposure of glioma cells to sonogramic therapy with 5LA induce apoptosis and necrosis. And in 2013, also in vivo, Dr. Uemura and collaborators showed that in an intracranial glioma model, sonogramic therapy was able to reduce the size of the tumor. And following this experience, also Dr. Kobayashi's group showed both in vitro and in vivo using the Incytic system that again, 5LA can be used as a sonosensitizer to destroy glioma cells in glioma cells. One limitation about 5LA is that it is selectively accumulated only by glioma, so this limits the type of tumor that we can treat. There are other substances that are used for surgical guidance and that are uptaken by brain tumors and other histotypes, and one is fluorescein. But fluorescein, it has to be said, it has some sensitizing characteristic. So we tested fluorescein as a sonosensitizer for sonodynamic therapy in a C6 glioma model, and we clearly showed that, for example, day 7 there is a decrease in tumor size compared to the control in rats. So this opened up new possibilities to treat other kinds of tumors, as fluorescein is uptaken also by other tumors such as ependymomas, meningiomas, and so on. So in general, sonodynamic therapy offers the possibility to treat brain tumors in a non-invasive and site-specific way, because the agent selectively accumulates in the tumor and we can focalize the ultrasound selectively in the tumor. Safety studies showed no damages to the surrounding brain, and there are 2 approved trials, one in the US and at Barrows, and one here in Milan, and we'll see what next. Thank you for your attention.
Hi, everyone. First of all, I'd like to thank the foundation giving me the chance to participate in this panel. Today, I would like to demonstrate our preclinical evidence using the focused ultrasound to open the blood-brain barrier and show the potential to trigger the anti-cancer immune response. Okay, so a little bit background review. The malignant brain tumor is the most aggressive disease with very poor median survival. And the current first-line standard treatment, including the debulking surgery and the concurrent temozolomide chemotherapy with radiation therapy. And the second-line treatment after the disease recurrence is indefinite and typically cannot extend the patient overall survival too much. A major issue is that the brain tumor is highly heterogeneous, with the surrounding normal tissue already tumor cell infiltrated, even though the peripheral blood-brain barrier is still intact. So while serving the radiation therapy as an important strategy for brain tumor control, it has traditionally been considered as an immunosuppressive tool, since the lymphocytes are one of the most vulnerable and radiosensitive cells within the body. And previously, there are evidences that showing that the radiation therapy dampened the immune response. But there are also evidence showing that the radiation therapy also needs this anti-cancer immune environment to boost its effect on tumor control. So in conjunction with the use of the microbubbles, the focused ultrasound has been shown to be able to temporarily open the blood-brain barrier and already know its potential to enhance drug penetration into brain to improve the treatment. So the raising question is whether the focused ultrasound blood-brain barrier opening can modulate the tumor microenvironment and trigger anti-cancer immune response. So here we show the first evidence. In our preclinical previous study, we found that solely using the focused ultrasound to open the blood-brain barrier can produce significantly increased lymphocyte infiltration effect, particularly the cytotoxic T CD8 lymphocytes, as well as the helper T CD4 lymphocytes. We also find the ratio between the cytotoxic and the regulatory T lymphocytes has a significant increase, which is a very important sign proving that the tumor microenvironment has been modulated to benefit the anti-cancer immune response. And unfortunately, in our recent clinical study, however, this tumor microenvironment change effect was not presented and observed. And we guess a possible reason is the pressure level is limited and still too low. So we redesigned another preclinical test to compare the difference of the immune response change between the clinical adult exposure level, that is the 0.68 mechanical index, as well as the excessive exposure level, 0.8 mechanical index. And this time, our analysis at day 7 with the 0.8 mechanical index again show a significant immunological response, particularly also the same for CD4 and CD8 lymphocytes. And this confirms that the focused ultrasound at such exposure level indeed can improve the tumor microenvironment toward the direction to benefit the anti-cancer treatment. So in conclusion, it is believed that having a better tumor microenvironment to facilitate the cancer treatment approach is critical. And the focused ultrasound blood-brain barrier opening already has evidence showing the capability in changing the tumor microenvironment through the recruiting CD8 lymphocytes. It should have the chance to provide synergetic effect when considering the focused ultrasound can serve as a tool, not only deliver the large molecular monoclonal antibody penetration, such as the immune checkpoint agent, but also can change the tumor microenvironment to make these agents more therapeutically efficient. Thank you.
Thank you again for this opportunity to speak and participate in the Focus Ultrasound Symposium. My name is Michael Lim, and I am a neurosurgeon at Stanford. My research interests are in immunotherapy and ways to combine it with focal therapies such as focused ultrasound. These are my relevant disclosures. So, as we all know, immunotherapy has been an exciting advancement in cancer. However, the results in glioblastoma thus far have been disappointing. We've seen very little responders, and if they are, they're more like case reports. And so when we look at glioblastomas, we realize that the immunosuppression is quite profound. It's not only local, but systemic. And we believe that the level or the resistance is due to two factors, an adaptive and intrinsic resistance mechanism to make these tumors particularly immunosuppressive. While there are many different approaches that are being utilized to overcome this immunosuppression, one approach that we've been particularly interested in was kindling. Now, the analogy I make is sometimes if you're out in the forest and you want to make a fire, if the wood is dry and you can put together the wood and usually start a fire. But if the wood is damp, you know that putting a match to it is going to be very hard to start a fire. So sometimes the strategy we use is to start with kindling, and then the kindling can overcome the damp wood to elicit or start a nice campfire. In essence, a systemic response. And so one of the, this idea came to me from one of the, from clinical experience. I do stereotactic radiosurgery as part of my practice, and I noticed in some of my patients, we observed very brisk inflammatory responses. This is an example of a patient that I did stereotactic radiosurgery to, and they got this very brisk T2 changes around the tumor. And it turns out that stereotactic radiosurgery can elicit an immune response through cytokines, upregulation of MHC molecules as an example. And so we thought perhaps this could augment or synergize with immunotherapy. So one of the approaches that we did was we looked at Jing Zhang when she was in my laboratory, looked at anti-PD-1, and she showed that anti-PD-1 could improve survival in animals with glioblastoma. But when you gave it in conjunction with stereotactic radiosurgery or focused radiation, you got this synergistic response, and it turns out that combination actually causes a very brisk ingression of immune cells. And so we found that this was thematic. We started looking at other immunotherapy combinations. Jennifer Kim, when she was in my laboratory, looked at TIM3 and found that when you gave TIM3 plus anti-PD-1 and stereotactic radiosurgery, again, we got this very nice synergistic response. And it turns out that we've done that with multiple other types of immunotherapies. And as a result, we're now looking at this in a clinical trial, trying to combine focused radiation with TIM3 and PD-1. Another idea of focal or kindling is the idea of using local chemotherapy. Demetrius Mathias and Jennifer Kim looked at this idea of changing the paradigm of giving systemic chemotherapy and just using local chemotherapy to induce an immune response. It makes it, you know, from a 30,000-foot view, if you give the chemotherapy locally, you could cause tumor cells to die and cause local inflammation, and you avoid the systemic immunosuppression of the chemotherapy. And so when we did this with BCNU and temozolomide, we saw again that giving this locally resulted in a very nice synergistic response, and this generated a lasting memory. These animals were essentially immunized against the tumors. So obviously this brings us to this concept of using focused ultrasound. Some people have been using laser ablation, but we are also excited with the prospect of using focused ultrasound, again, to create a local immune response. I mean, a local kindling to elicit a systemic immune response. And so there are multiple groups now that are looking at this concept of combining focal ultrasound with immunotherapies. So, you know, in conclusion, initial immunotherapy results have been disappointing in glioblastomas. We think it's because there's a high intrinsic and adaptive resistance mechanisms in the glioblastoma, and that perhaps using a combination approach with kindling could perhaps help us overcome this immunosuppression. I want to acknowledge my laboratory, folks. I get to work with a lot of bright and brilliant people, and I feel grateful to be able to work with them. And again, I have the same admiration for the people I work with on the clinical trials side and our brain tumor immunotherapy program. Lastly, I want to acknowledge our funding. Thank you for your time.
Hello, everyone. My name is Chun from Washington University in St. Louis. It's my great honor to join the Brain Tumors panel. I would like to take this opportunity to briefly introduce the Sonov biopsy technique for blood-based molecular diagnosis of brain diseases. So the treatment of brain tumors has been improved over the past decades through precision medicine, which requires an understanding of the genomic profile of the disease. However, there's an unmet need where the current neuroimaging and tissue biopsy techniques are unable to non-invasively characterize this molecular signature. Magnetic resonance imaging is the standard of care for brain tumor diagnosis, but it cannot provide molecular level information. Surgical tissue biopsy can examine the tumor pathology, but it can only be performed once or twice because it's very invasive and may not be possible for many patients. Our solution is Sonov biopsy that enables blood-based molecular diagnosis through non-invasive focused ultrasound. So the blood-brain barrier is known to be the barrier that limits the delivery of drugs from the blood to the brain. It also blocks brain tumor biomarker release into the bloodstream. Blood-based liquid biopsy has been used to non-invasively determine the genomic profiles of patients with many cancers outside the brain, such as breast cancer, pancreatic cancer. This is because these cancers can shed their DNA, RNA, or proteins into the bloodstream. However, limited progress has been made for brain tumor liquid biopsy, partially because the blood-brain barrier limits brain tumor biomarker release into the bloodstream. Focused ultrasound combined with microbubbles has been established as a promising technique for mechanical disruption of the blood-brain barrier. It has been used in preclinical and clinical studies for non-invasive and localized delivery of peripherally injected drugs into the brain tissue. We hypothesized that focused ultrasound-induced blood-brain barrier disruption enables two-way transfer across the blood-brain barrier. Drugs can be delivered from the blood to the brain for the treatment of brain tumors, and tumor-specific DNA, RNA, and other biomarkers can also be released from the brain to the blood circulation, enabling the diagnosis of brain cancer through a simple blood test. We call this technique Sonov biopsy. We have demonstrated the feasibility of Sonov biopsy using a mouse model of glioma developed by implanting green fluorescent protein or GFP transfected glioma cells into the mouse brain. We selected GFP mRNA as a reporter gene to represent brain tumor-specific biomarkers. And we found that Sonov biopsy enhanced the plasma GFP mRNA level by more than 1,000-fold, as shown in the graph on your right. We also show that Sonov biopsy is feasible in a large animal model, pigs. Successful blood-brain barrier opening was achieved along with observation of enhanced plasma concentrations of two brain-specific biomarkers, protein biomarkers, GFAP and MBP. Clinical studies are needed to further assess the feasibility and safety of this technique. If successful, we believe Sonov biopsy has a potential to become the third pillar for brain tumor diagnosis following neuroimaging and tissue biopsy. It would provide complementary molecular information about the brain cancer without the need of surgery. So in the future, the application of Sonov biopsy can be expanded to the diagnosis of other brain diseases, such as Alzheimer's disease. And I want to thank you for your attention, and I'm looking forward to further discussion with the panel. Thank you.
So I'd like to thank the group of panelists here today for joining me. I had an opportunity to watch the talks in a pre-recorded fashion, and I know that a number of our audience members have just watched the live stream of those talks. And I found that the talks were absolutely outstanding, well delivered, and the scientific data quite robust. I guess I will start off with some of the questions that were in the live chat. And the first question I saw was for Dr. Sonov. The question was about the SonoCloud 9. How many of the 9 implanted transducers were activated simultaneously during patient treatments?
Yeah. Thank you, Jason. First of all, it's a pleasure being here with the group, and I'm very, very grateful for the Focus Ultrasound Foundation and to you for organizing this great event. So as far as that question goes, we actually turned on all transducers at the same time. There was a previous clinical trial that we just finalized. We're just following patients now, in which a number of transducers were turned on escalating cohorts. But the last cohort had all the ultrasounds turned on. I actually implanted 4 devices that had that. And so for a paclitaxel trial, we started with the patient 1 already with all devices, all transducers turned on at any given point.
Wonderful. And so the data leading up to that, though, you had varied and studied this, and that was not something that you presented today, but the SonoCloud 9, do you anticipate that there would be additional permutations in terms of the technology, or is 9 in your opinion, the optimal implantable transducer for this type of approach?
So I think SonoCloud 9 is already a huge technological advancement. The area of sonication is pretty broad. The ease of turning on the device and getting sonication without MRI guidance, the robustness of the sonication field, the fact that it takes about 4 minutes to do the whole thing, I think it's already a huge breakthrough. I don't have additional information from the company that developed this, from Carthera, on additional new technologies that are on the horizon. I'm sure they're always working on something interesting, but right now I think this is enough for us to test the approach. If we can target the peritumoral brain with this large field, I think might show if the approach works or not. If in the future a larger tumor requires additional devices or increased field, that might actually be in a room for improvement.
And I want to underscore what you just said earlier, which is that this process was about a 4-minute process. Is that correct?
That's correct. It's a 4-minute process, does not require an MRI. It's done at bedside on an infusion suite as an outpatient. Essentially, we sterilely insert a transdermal needle that goes into the ultrasound port through the skin. We connect that to the pulse generator. We inject microbubbles. We activate the device, and 4 minutes later, the blood-brain barrier is open.
So it certainly speaks to the ease of use and the ability to integrate this into standard clinical practice, if and when that comes, when that time comes. The next question that came through the chat room was for I believe Dr. Liu. It says, excellent talk. Why do you think that the higher MI had a greater immune response? And what were your pulsing parameters? I think you're on mute, Dr. Liu. Thank you.
Hi, Jason. Thank you. For as to this question, is originated from our previous observations that lower ultrasound exposures indeed have some effect, but it's not enough. So what we observe is the lymphocyte infiltration rate indeed correlates with the ultrasound exposure level. And what we notice is the higher pressure level can cause some red blood cell extravasations. We are guessing the extravasations of the RBC is the reason that the CD8 plus lymphocytes infiltrate into the tumor. So that's what we're guessing. So we don't have the full answer, but we are thinking from the preclinical evidence and from the clinical evidence we found, because in clinically, we cannot use this high pressure level for the patients. So we do not observe anything, but indeed we can see from the animal. So that's why we are choosing this kind of suspicions to that kind of situations.
Thank you. Another question from the audience came for Dr. Chen. Dr. Chen, the question is about, would sono biopsy potentially enhance the opening of the already defective BBB around tumors in the brain for biopsy?
Yeah, I first want to thank Jason and the organizer for putting together such a wonderful panel of experts. So regarding the question, so the answer is yes. So the concept of sono biopsy is, in terms of technology, it's not different from opening the blood-brain barrier for drug delivery. We just build on current technology advancement in focused ultrasound-induced blood-brain barrier opening to propose the concept that we are going to use this technique to release brain tumor-specific biomarkers from the brain to the blood. So currently, it's already known that we can precisely and reversibly open the blood-brain barrier around tumors or basically anywhere in the brain. So I think the sono biopsy, which we call sono biopsy, means focused ultrasound-enabled blood-based liquid biopsy. So the concept is, compared with existing blood-based liquid biopsy, we have the advantage of being able to pinpoint specific locations in the brain to obtain the blood biomarkers. And then compared with existing tissue biopsy, we offer a non-invasive way to diagnose the brain tumor. I hope I addressed the question.
You have and done well. This is a great audience, and engaged audience. That's clear. Dr. Lim, I wonder if you could comment a little bit about the technical challenges in terms of clinical fuss-mediated BBB opening for immunotherapy. Where do you see those technical challenges, and where do you see the opportunities for BBB opening for neuro-oncological pathologies and accentuating the already integral part of immunotherapy for treating many neuro-oncology patients?
Sure. Thank you for that question, Dr. Sheehan. And I too wanted to say thank you again for inviting me, and I'm really honored to be part of this panel. I think that I think you asked a great question, and in fact, it's probably part of a bigger question, right? With our therapies, we actually are very precise in where we can deliver the energy to the tumors, and so we can sculpt and we can deliver that energy to the entire tumor. We can deliver it to certain parts of the tumor to disrupt the blood-brain barrier. And so there's been a lot of excitement for it. And, in some ways, I say it depends on the immunotherapy you want to do. Some of these small molecule inhibitors do need to traverse the blood-brain barrier. And so, in those situations, you may want that to go across. But however, I think what we've learned, at least with some of these checkpoint inhibitors, for example, they actually do traverse the blood-brain barrier. And actually what happens is a lot of the antigen presentation and activation actually happens outside of the brain. We have a paper that's coming out showing that it's actually in the cervical lymph nodes. And so then it's just a matter of, maybe you want to use the energy to try to maximize the chances for antigen presentation for the tumors. So, again, I think it depends on the therapy. If you have, just to summarize, if you have something like a small molecule, you may want to try to get the entire tumor and try to break up the blood-brain barrier. However, if you have some of these other therapies that activate or antigen presentation, then you may need to be a little bit more selective and more thoughtful with that.
Certainly, there is a growing use of immunotherapy approaches, not just for primary brain tumors, but for secondary ones as well, metastatic disease. I know we focus a lot of our efforts on discussions on the realm of primary brain tumors, particularly in the preclinical arena for focus ultrasound. Pivoting back to talking a little bit with Dr. Prata about the idea, there was a question for you, Dr. Prata, about could you clarify the difference between 5-ALA and fluorescein in terms of the incubation time and cell killing effect?
Yeah, thank you for this is a great question. Good morning, everyone. I want to I'm honored as well to be here in this panel. So this is a great question. The 5-ALA and fluorescent are totally different in their action and how they accumulate in the tumor. So basically, the 5-ALA is metabolized by tumor cells, whereas fluorescent extravasate in the extracellular space. In terms of the cell killing effect, both are deemed to work based on free radicals productions, and this is due in both cases probably by the interaction between the ultrasound and the sensitizer. But the mechanism is still not totally clear. They both induce apoptosis and necrosis. So we tested both in an animal model at the University of Virginia, and in both cases the outcome was similar, and the mechanism of action was probably similar. We used the same sonication parameters. So, and actually, I think that part of the effect is due by the ultrasound per se. We did some preclinical in vitro study here in Milan as well, and we found a smaller degree of induction of apoptosis and necrosis with ultrasound alone in vitro. And I think, both the sensitizers, they enhance something that is already induced by the ultrasound.
There was another question for you, Dr. Prada, that was talking about do you think that sonoluminescence may activate sonosensitizers to generate reactive oxygen species for tumor eradications? Wonder if you know about that.
That's a great question as well. So when I first heard about sonoluminescence, I was kind of skeptical because I'm a neurosurgeon. I was not able to imagine how sound can induce light in tissues. But I had the chance lately to work with colleagues who are doing optoacoustic imaging, where basically you use light to generate sound, and you generate the image with an ultrasound image. So this is basically the opposite. And we can call this a sort of instead of sonoluminescence, can be a phonophotic effect, using Greek terms. But yes, definitely I think this could be a mechanism of action.
Thank you. A question for Dr. Lim. It was regarding whether or not there would be sufficient penetration of checkpoint blockade to tumor cells when there's only non-enhancing tumor after just non-enhancing tumor left after resection. Obviously, the gadolinium is a surrogate for blood-brain barrier disruption and a concentrated region of tumor cells, but in instances where you're generally speaking about non-enhancing tumor, I presume this is more around the realm of glioblastoma or high-grade gliomas as compared to DIPG or other things we talked about earlier today. But Dr. Lim?
Thank you. So that's a really interesting question, and I think the bottom line is I'm not sure. I don't know that answer. It's interesting. BMS had a very nice modeling algorithm that they developed, and some of it was verified with tissue, and they do think that in general for brain tumors, including enhancing and non-enhancing, that the checkpoints do reach the non-enhancing area that they're able to traverse. The question though is, are they all basically backpacking on top of the T cells that might be circulating in there? Because there are some, it's very rare, but there are a little bit of T cells in there, and if that's what they're picking up, because some of the T cells are doing surveillance. But one would think that there's probably less because there's less immune cells in there, and the biodistribution is probably different in a non-enhancing area than an enhancing area. But that would be my guess, that there would be some, based on some of the preclinical work that I've seen and modeling for human studies that I've seen.
We talk a lot about getting things in, of course, and we touched a little bit upon this Sonov biopsy potential. There was a paper that came out in Neuro-Oncology just a couple months ago, and there have been other papers showing the genetic drifts that are predominant in primary as well as secondary brain tumors. But I'd be interested to know your thoughts, Michael, on the ability for use of focused ultrasound for accentuating some of the liquid biopsy work that we're doing, and whether or not we may be in some instances able to use this to be very strategic about the genetic drift and targeted therapies that we may be trying to get across the BBB, not just using the information to gather what may be a change from primary to secondary, or differences between one tumor, for instance, that may have responded well to radiosurgery versus another tumor in a different lobe of the brain that may respond less well to radiosurgery and need BBB opening and targeted immunotherapy.
Yeah, I mean, I think, Dr. Sheehan, that what you mentioned is probably, I mean, hopefully we get to a point where we kind of have a journey, and where these tumors evolve and they change, we have ways to monitor and then redeploy our therapies. I think that's a great point. I mean, I think, as we looked and learned from the lung cancer folks, right, there's all these driver mutations that happen. And so, it's an interesting question, because I think what you bring up is the fact that glioblastomas, I think you're referencing also the fact that there's these studies that show that two different regions of the tumor have completely different genetic makeups, different immune microenvironment, and even different subtypes. I think Mario Suva showed that paper. So, hopefully as we get more sophisticated with imaging, and then we have these precise therapies like focused ultrasound, you're right, we can maybe start going at these tumors piecemeal, and maybe that region A needs targeted therapy, region B needs immunotherapy, and region C needs, just complete ablative therapy. And I think what you're doing, a lot of people are doing with what they call cell-free DNAs and stuff can certainly give us insight and questions. I think what you're getting at is perhaps you could hit a certain part of the tumor with your focused ultrasound, break it up and see the genetic makeup, and then develop radiomics for it or something. I mean, develop some sort of targeted therapy or immunotherapy, right?
Indeed, and certainly you can get some insight into tumors that may evolve as a function of time. Well, there's an awful lot of tremendous number of questions from the audience, and the talks were outstanding. I want to thank all of you for joining us today, and looking forward to further discussions in the future around this exciting field. Thank you so much.
Thank you.